Right. Well, over the last several years, we've evolved to the point at the Yale Cancer Center Smile Cancer Hospital to test pretty much all of our new patients for mutational profiles. Certainly, you're more likely to find actionable mutations in non-squamous lung cancer, but we tend to do it for all the non-small cell lung cancer because we know that you can find those mutations in the squamous cell patients as well. The most important things to have, the day you see the patient with newly diagnosed disease would be EGFR, epidermal growth factor receptor, ALK, anaplastic lymphoma kinase, and then ROS1. Those three I would want to have because if a patient had one of those mutations, that would lead me to give them an oral targeted therapy. Now, in the last 6 months, we're very focused on PD-L1. We've actually put in place at Yale New Haven Hospital the ability to have PD-L1 testing done before the patient comes to see us. So it's done as a reflex. And PD-L1 is important because for those 20% who have high, meaning 50% or more membranous staining for PD-L1, they can get pembrolizumab. So EGFR, ALK, ROS1, and PD-L1. Certainly we have the ability to look for another 50 or 60 genes in a small panel and a larger panel of 409 genes that we do. But usually we save that for patients who are looking at next steps at looking for early phase trials. A driver mutation is found in the United States in about 15 to 20% of patients, probably closer to 15. So most patients with non-small cell lung cancer will not have a driver mutation. Most patients are smoking-related lung cancer patients. 20 to 30% will have a RAS mutation. That is a driver mutation. That's one that we don't have much that we can do about. So we have about 80+% of the patients who have genotypes that are not actionable with any new targeted drugs. So that's a group that really is important to identify. And of course, the immunotherapy is now offering new hope to this group. PD-L1 is not a perfect marker. We know there's heterogeneity. We know there could be differences depending on how you score it. But that said, it has panned out, especially in the studies with pembrolizumab, the KEYNOTE-1, the KEYNOTE-10, which I led, the KEYNOTE-24, that it is a positive predictor for activity for the PD-1 inhibitor. So now, given that frontline therapy is used based on positive PD-L1 status, it is measured certainly at our hospital, and I would make the case that every hospital and every patient should ask for that. Because if you're one of those 20, 25% where you can get PD-L1 testing and you have a positive result, and you're one of those patients who can get pembrolizumab alone versus chemotherapy, I would say that you would want that. A patient would want that.